Hi there, my name is Mike Pishfine. I'm an associate professor of GI medical oncology at Johns Hopkins University. Welcome to our case presentations. We have a wonderful panel here with us today, and we're going to go around and meet an individual member first and then discuss some cases. I'll go next to Dr. Fromm.
Yeah, hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I have appointments in abdominal imaging and nuclear medicine, and I'm happy to be here today to go through these cases.
Hello, I'm Pritesh Patel, associate professor of radiation oncology at Emory University, focusing on GI malignancies.
Hi, I'm Dan Catenacci. I'm a GI medical oncologist at the University of Chicago and an associate professor there.
Hi, I'm Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
69-year-old male diagnosed with stage 4 pancreas cancer, who, after having received neoadjuvant chemotherapy and surgery with a plan for concurrent chemoradiation. So should this patient be offered concurrent chemoradiation in the context of metastatic disease, and what other options could be offered? So this is a patient who presented with painless jaundice while hospitalized for an acute coronary syndrome, had a moderate peak performance status in ECOG of 1, the history, of course, of coronary artery disease, hypertension, as well as hyperlipidemia, no history of tobacco, alcohol, or drug use, and no family history of cancer. So on February 2020, the patient had an MRI, which showed a 1.5 centimeter liver lesion in the dome, suspicious for metastatic disease, as well as a sub-centimeter lesion in segment 8. And Dr. Fromm, we have the MRI, correct?
I believe we just have the PET images on the next slide.
Okay.
But yeah, I can
go ahead and go
talk about those. Sure. So I guess one thing that we'll say about the MR, I'll sort of touch upon that after we go through the PET findings. But so we see here on the PET that we have an FDG-avid lesion that's outlined with that red contour on the two right-sided images, which are CT and PET images, top and bottom there. The image on the left side, I believe, is from after the Whipple, so kind of showing some post-operative anatomy. I think that might have been for the adjuvant radiation planning. But the lesion of the pancreatic head and neck is ill-defined and kind of moderately hypermetabolic. We're also told that there was a hypermetabolic portocaval lymph node, which is not seen here. We were also told in the case, we don't have an image to support this, but there are a couple of liver lesions, one of which was 1.5 centimeters in size, but was not seen as a hypermetabolic lesion on the PET CT. So, pancreatic cancer is variably FDG avid. Some lesions are markedly hypermetabolic. Some of them are sort of barely above the background pancreatic parenchyma. But oftentimes, the metastases will recapitulate the imaging findings of the primary. So if your primary is going to be avid, you can expect your metastases to be avid as well. Generally, a 1.5 centimeter metastasis coming from an avid primary should be avid as well. Smaller, less avid lesions oftentimes will not stand out above the background of the liver parenchyma, but this would be one of those scenarios where, if you were to end up with this kind of situation where the MR is telling you one thing, but you don't see the lesion on PET, it'd be a good idea to speak with your radiologist, have them re-review the imaging and sort of make sure that they are confident that we are dealing with a metastasis here, because there are some lesions in the liver, like sclerosed hemangiomas, for example, that can look very much like a metastasis. So just a little bit of sort of discordance there that I think would need to be sorted out, just to kind of confirm that we really do think that this is stage 4 disease. Going back to the previous slide, I guess the fact that the lesions decreased in size on neoadjuvant therapy does, the liver lesion specifically does sort of support the assumption that these were in fact metastases, and that for whatever reason they're just displaying kind of a different phenotype on the PET CT than the primary lesion.
The number that I often quote, I want to make sure it's still up to date, is that pancreatic cancers that PET scans have about a 65% sensitivity in pancreatic cancer. Is that about what you recall?
Yeah, I mean, it varies by the study and whether we're talking about the primary versus nodes versus distant metastases. But that number sort of intuitively rings true for me. I would say that I find PETs to be helpful. It's probably somewhere around 50% of the time in these pancreatic cancers. We don't routinely utilize PET-CT at our institution for imaging these patients at initial staging anyway.
All right, Dr. Weiser, you're asked to do this Whipple on this patient, but you know that they had a 1.5 centimeter liver lesion. What steps would you go through to try and rule out or rule in that there was a metastasis there?
Yeah, I mean, I think you can try to do image-guided biopsy beforehand, of course. I think that would be important. Laparoscopy is always a good idea to look for peritoneal disease, and you could try to do intra-operative laparoscopic ultrasound guided biopsy as well, although the interventional radiologist may have an easier time at it.
Yeah, so I was going to actually ask you about that. I'm glad you brought that up. So intraoperative assessment, I find my surgeons not infrequently being very proactive in assessing the liver specifically when they're about to start a Whipple. So what techniques do you go through in the operating room to try and make sure that there's nothing in the liver or on the liver?
Yeah, I think you'll often start with laparoscopy, which will scan the entire peritoneum, and then laparoscopic ultrasound, I think, is a very good technique. Looking at all segments of the liver for lesions is very helpful. Some may just look for peritoneal disease and then do open ultrasound, but I think it's critical to rule out metastatic disease.
And forgive my naivete, it's actually fascinating to me. So laparoscopic ultrasound, so one of the ports, whatever, has an ultrasound on the end of it?
That's right. So you have an ultrasound that will go through a port with a flexible tip that allows you to follow the contour of the liver.
Interesting. Okay. All right. So we'll assume that this patient was sort of, again, we use the term given the benefit of the doubt and hoping that the liver lesion did not end up being metastatic disease. And then they underwent the Whipple surgery. The Whipple revealed a 3.8 centimeter pancreatic mass, but unfortunately with a positive margin. 15 lymph nodes, however, were negative for cancer. And then post-operatively, there was no clear evidence of recurrence immediately post-operatively. So the question is, did this patient's liver lesion disappear? Was it not cancer to begin with? We really don't have biopsy to know one way for sure or another for sure. So what would you do in offering adjuvant post-operative chemo or chemoradiation? We're not given the information as to how much chemotherapy they got. I'm assuming just from the timing, maybe as much as 4 months, I'm guessing. Dr. Catenacci, would you guess that much from this history?
Yeah, that's what it looks like. So, the notion of moving an adjuvant component of therapy up before surgery in pancreas cancer, so-called TNT, or at least partial, is becoming more and more common. There's actually a study, an Alliance cooperative group study looking at this in a randomized fashion, but many of the centers have been doing this already. And so the answer to your question, would I give some more after now? It would depend on how much they got preoperatively. Typically we like to try and complete a 6-month course. So if they finished 4 preoperatively, we might do 2 months postoperatively. There is the problem here that the patient has reported neuropathy and they had to already stop the oxaliplatin. So you'd have to reassess that, and potentially if that's improved, you might re-challenge. Some other things I'd be looking for though are, in the pathology specimen, was there evidence of response? What's the grade of response to determine whether or not it would be, warranted to continue with the same therapy. We have evidence in the liver, at least, that it responded, but we don't really know what it was to begin with. So these would be things going through our mind. And in this scenario where we thought we could give more of the same and we thought it was effective preoperatively, we would complete the 6 months postoperatively, potentially with a chemo-RT component here with an R1 resection. And if we didn't think they were responding, and or we thought we couldn't give more oxaliplatin for whatever reason, sometimes we switch to the alternative, which is gemcitabine and nab-paclitaxel, in the setting where if they have an R1 resection, we think they're potentially metastatic already or residual disease, and start treating them with some other therapy, the rationale being maybe that this will have a better response, and probably include an RT component there too.
And then Dr. Patel, your thoughts on treating this patient for adjuvantly with chemoradiation, but actually also comment on what if this patient had received pre-operative chemotherapy.
Yeah, sure. I think we don't have information here, maybe about the primary, the vascular interfaces, but maybe with a positive margin, presumably a borderline resectable pancreas case to begin with. And I totally agree with Dr. Catenacci that we're more often giving almost all of the therapy neoadjuvant, the systemic therapy and radiation therapy at our center. So in a borderline case, we probably would have proceeded with the chemoradiation prior to the surgery in a case like this. And now, I think we've as a group, with what's happened, have gone down the treatment pathway with definitive intent. And so in that case, I would, we've got negative lymph nodes now, even they were positive at diagnosis. So, good response in the liver, I think with a positive margin, that to me is a clear indication to use adjuvant chemoradiation. And I would give a standard, typically large field treatment encompassing the lymph nodes, the pre-operative extent of the primary disease, as we saw in the imaging, and then the anastomoses. So I would do that with probably with concurrent Xeloda.
Dr. Catenacci, what do you think about the idea of this is a patient that you think that there was a liver lesion, think that it might have had a significant response to the point where it disappeared radiographically, but you still feel that there was something real there. And then you finish up a total of 6 months of FOLFIRINOX. Are you a watch and wait person after that, or would you consider doing anything else?
Yeah, so conventional wisdom, I was going to say we are, it seems like we're all, on board with going after this in a more aggressive manner, but we would have to, go in eyes wide open, and with the understanding that the recurrence risk here would be exceedingly high, obviously with an R1 resection and potentially liver metastases from the get-go. So your question's a good one then. So probably if we went with a definitive approach, we would take it some time off and see where we're at. The patient's been through a lot, the surgery, all the chemotherapy, the radiation. We would probably give a break and watch and wait. It opens the door for the whole question about MRD testing, minimal residual disease testing with ctDNA, which doesn't have a lot of evidence here other than it's a prognostic biomarker. And if there was still evidence of ctDNA positivity after all of our therapies, that would not bode well for the patient. But what we could do about it, that's unfortunately not known. And so probably I would watch and wait, and with the understanding that it's more likely than not going to come back at some point, and we would deal with it at that point.
Yeah, I have to say, so we had published on using maintenance capecitabine a few years ago, where this was a purely retrospective look at patients who underwent a resection, and then some of the patients had received a long course of maintenance capecitabine on a tolerable schedule versus just a standard watch and wait. It was just one paper. It was just, ultimately 60 patients and purely retrospective. And for many years, I was using that approach. Lately, I've switched back. There's certainly no prospective evidence. We did try and get a trial in this area push through the alliance, but it just never really materialized. I think it's an important question because in this case, especially, are you treating ongoing metastatic disease with some sort of therapy that could continue to suppress recurrence or regrowth, or are you just waiting for it to grow back? And then one more question I was going to ask Dr. Weiser. So there are groups, including ours and many other centers, that are really toying with the idea of being more proactive and more aggressive of isolated liver metastases for pancreatic cancer. This is patients, not quite like this patient, but somebody who's known to have an isolated liver lesion, gets a period of chemotherapy, does great, and that liver lesion is still there, and the primary tumor is operable. Would you consider, certainly I'm sure you would say yes to a protocol, but would you consider off protocol a resection of the liver metastasis?
Well, that's definitely not standard, but there are people doing it, and there are trials actually for intraperitoneal chemotherapy as well. But those are clearly best studied with a trial, so we can come up with an answer. So I would urge them in that setting to go on trial so we learn something. So it's not generally our practice to do that, but there are always exceptions.
Okay. All right. Definitely a challenging case. Any other thoughts about this case before we move on?
I would say, in that setting of the oligomets, we actually have a study in that situation for any upper GI cancer that presents with oligometastases like that. And it is the requirement to be eligible is that you have 4 months of induction chemotherapy of physician's choice as pertinent to the upper GI cancer. And then they have an MRD ctDNA test pre and post, and it has to clear to even be considered eligible. And then there's a randomized surgery or just continued palliative therapy to see if there is benefit from intervening with debulking surgery.
That's a great study. Is it just a single institution study?
It is. It's at our center at the moment.
I hope it accrues quickly so we can get an answer.
Yeah, that is a great study, and it is really the only way we'll figure out what to do here. Retrospective studies won't help us, of course, but this
Right. Selection bias, of course.
All right, very good.